Upstate Medical University in Syracuse, New York invites you to Be the Informed Patient with the podcast that features experts from Central New York's only academic medical center. I'm your host, Amber Smith. Today, we're learning about an autoimmune disorder called rheumatoid arthritis from Dr. Patrick Riccardi. He's an assistant professor of medicine specializing in rheumatology at Upstate. Welcome to the Informed Patient, Dr. Riccardi.
Thank you, Amber.
Now, just to be clear, osteoarthritis, when your joints are damaged by wear and tear, is not related to rheumatoid arthritis. Is that right?
Yes, they're quite different conditions. Rheumatoid arthritis is associated with a lot of inflammation, as opposed to osteoarthritis, which is primarily a non-inflammatory degenerative process.
Do people who have rheumatoid arthritis get osteoarthritis?
They're more likely to get it, indeed. Anything that damages the surface cartilage can lead to secondary osteoarthritis, secondary degeneration. Our treatments are better today, but when I first started practice many years ago, it was one of the leading causes of joint replacement surgery. That's changed, but anything that leads to damage to the surface cartilage, such as rheumatoid arthritis inflammation, could lead to secondary degenerative arthritis, yes.
So, how do people typically learn that they have developed rheumatoid arthritis?
The symptoms typically originally are pain and stiffness in the joints, multiple joints. The distribution of joint involvement tends to be the small joints, hands, feet, wrists, oftentimes elbows, shoulders, hips, and knees are involved in a bilateral, symmetrical, which means both sides of the body type of involvement, which is different than osteoarthritis, which tends to come on with age, usually after the age of 40, and involves fewer joints, and it's not as symmetric in location. It tends to dominate in the lower extremities, the hips, the knees, the low back, and the high usage joints of your hands, such as the base of your thumb, the distal interphalangeal joints, the small joints of your hands, giving you what looks like knobby knuckles in appearance.
Is pain associated with this? And how do patients describe what it feels like?
Pain is the prominent initial symptom. And stiffness, prolonged morning stiffness. Typically, a rheumatoid arthritis patient will have stiffness that lasts at least a half an hour, and it can go on all morning long. Whereas an osteoarthritis patient, the stiffness is brief, usually lasts maybe 5 minutes, and once they move about, they're okay. However, with degenerative arthritis, when you've lost the surface cartilage, usage of that joint, such as weight-bearing activities, will aggravate the symptoms. And just the opposite is the case in rheumatoid arthritis, where the morning stiffness is usually alleviated by movement, and the patients feel better once they move about.
Are there any tests that are done to determine for sure that it's rheumatoid arthritis?
Yes, both x-rays and laboratory tests are done. There's a couple types of antibodies that are typically present in over 80% of rheumatoid arthritis patients. One is called rheumatoid factor. Another one is called a CCP test. Furthermore, those patients typically will have elevated markers of inflammation in the blood work. The sedimentation rate, the CRP test are two measurements of inflammation. They should be up, whereas a typical degenerative arthritis patient, they're normal.
Are there any body parts or body systems that may be involved beyond the joints?
Yes, it's rheumatoid arthritis is an autoimmune disease. It's a systemic illness. And once your immune system, your body's defense system is activated, it can react against your own tissues, not only the lining of the joints, which is the most predominant joint involved in rheumatoid arthritis, but also the lining of the heart and lungs. It can give you pericarditis and pleuritis. It can give you interstitial lung fibrosis, which causes stiff lungs and difficulty breathing. It can lead to chronic inflammation of your blood vessels, which predispose you to myocardial infarctions and congestive heart failure. It can irritate the lining of the eyes, the sclera, and lead to quite a bit of damage. And at times, the skin and blood vessels are also involved as part of the autoimmune portion of rheumatoid arthritis.
Do we know what causes this?
We still don't have full knowledge of all the factors that cause rheumatoid arthritis, but we have learned that the initial steps likely involve environmental triggers in patients with genetic predisposition, and environmental triggers specifically at mucosal surfaces, such as exposure to cigarette smoke in our airways that lead to damaged proteins of the lining of the bronchial mucosa. Smokers have an up to a 20-fold increased risk of susceptibility to rheumatoid arthritis. People with periodontal disease, gingivitis, with altered gum mucosa will have an increased expression of rheumatoid arthritis versus the general population. And also a big factor may be our gut microbiome. Our Western diets are pro-inflammatory. A lot of highly processed foods, a lot of sugar can alter the gut mucosa and alter our gut microbiome. And it's thought that certainly can affect the expression of rheumatoid arthritis. Diets like the Mediterranean diets, for example, that help restore the healthy microbiome are associated with improvement in rheumatoid arthritis expression. So we know that there is an environmental trigger involved in many, many patients. There's also the risk factors of genetic predisposition. First-degree relatives of patients with rheumatoid arthritis have approximately a 3 times increased incidence of rheumatoid arthritis. Even second-degree relatives, grandparents, aunts, and uncles, have a 2 times increased incidence. So there's both genetic factors and there's environmental factors. An interesting statistic is that with identical twins, you have a concordance rate of rheumatoid arthritis in the other twin only 15% of the time. So if you have rheumatoid arthritis in your identical twin has a 15% chance of getting it. That means that there's something else involved here, not just genetic predisposition. And those environmental factors that we talked about are probably prominent.
You mentioned among the environmental factors cigarette smoking. Does that apply to secondhand smoke inhalation as well?
I've not seen a study on that, but I'm sure it does. Knowing the increased risk that smoking conveys on developing rheumatoid arthritis, we have stressed to patients to stop smoking. We've been doing this for other reasons as well, obviously. But if we can successfully get them to stop smoking, the chances of them develop rheumatoid arthritis diminish with time. So I'm sure secondary smoke and ongoing smoking are not good for you.
This is Upstate's The Informed Patient podcast. I'm your host, Amber Smith. I'm talking with Dr. Patrick Riccardi, a rheumatologist at Upstate, about rheumatoid arthritis. So let's talk about treatment. Is there any way to reverse the tissue damage?
Unfortunately, the short answer is no. However, you can certainly improve the function of the patient with proper alternative therapies, physical therapy, occupational therapy. But once the damage has occurred, it tends to be permanent. The key to successfully treating rheumatoid arthritis is to diagnose it early. And in most patients, they will have progressive joint damage and disability if they're untreated. So we nowadays treat quickly with immunosuppressive medication, what we call disease-modifying anti-rheumatic drugs. Methotrexate has become the mainstay of therapy. Weekly methotrexate is typically the first immunosuppressive drug we use. In about 40% of patients, it will be by itself alone able to reduce the rheumatoid inflammation to either a low level or a full remission. The other 60%, we typically have to add additional immunosuppressive medications. Thankfully, in the last 20 or so years, we have developed more targeted therapies called biologics, which have really been a game changer. I started way back in 1981. We had lousy drugs. We had gold and penicillamine, and they were very ineffective. They might work for mild rheumatoid arthritis, but for moderate or severe rheumatoid, they were very poor therapeutics. About in the late 1990s, the first group of biologics came out: Enbrel, Humira, Remicade, the anti-TNF more targeted drugs against TNF is a protein, a cytokine that's produced in excess in rheumatoid arthritis. Anyway, it quickly changed the outcome of the majority of patients. And we've now developed other targeted therapies, other biologics, which have also really changed the outcome of these patients.
Are there complications for rheumatoid arthritis that treatment can help prevent?
Absolutely. When we talked about joint damage, when I started, I'm going to guess joint replacement therapy was occurring in rheumatoid arthritis patients equally with that of degenerative arthritis. That ratio has flipped with the advent of the new medication. So joint damage and disability is markedly reduced with effective immunosuppressive medications, but also the complications of cardiovascular disease. Until the newer medications became widely available, it was the leading cause of premature death in rheumatoid patients from causing plaque-like formation in the blood vessels, leading to stroke, heart attack, congestive heart failure. That's all much improved with our newer medications, plus a knowledge that this is a risk factor for rheumatoid patients, and we pay more attention to their cholesterol levels and the treatment of their blood pressure and those types of things. The fibrotic changes of interstitial lung disease, which occurs now in up to 10% of rheumatoid patients, that also is diminished with effective immunosuppressive therapy. Scleritis, which can be terrible. I've seen some awful cases where we've actually had perforation of the outer layers of the eye. That is also improved and much less frequent with these newer medications. Really, all the organs that are involved with rheumatoid arthritis are much improved with our newer medications.
Well, with these new medications, what is life like for someone with RA? How debilitating can this be?
It can be severely disabling. It used to be one of the leading causes of disability. With effective treatment in high-income countries like the United States, where we can afford to use biologic medications, probably 90% of the joint destruction can be avoided if we can get the patient on the right medication. But not everybody. There's something called difficult to treat rheumatoid arthritis that still occurs in 10 to 15% of rheumatoid patients. Those patients will have ups and downs in their disease activity. And they can do very poorly without taking the proper medications, or if they happen to be in that 10% who don't respond to the current medications.
All of these different medications, do they leave people with RA immune suppressed?
Absolutely. It's always been the big concern. Are we going to cause more harm than good? Fortunately, the infectious risk for most patients is less than 1% for serious infection. However, we carefully choose which patients go on them. If the patient has a tendency for infection, if they have COPD with emphysema and recurrent bronchial infections, if they have cellulitis with recurrent bacterial infections of their legs, if they're a diabetic, all those patients, we are very careful to use them. A lot of times we don't use them at all. There are specific groups that you can't use certain biologics with. If somebody has a history of lymphoma or melanoma, we can't use the Enbrel, Humira, anti-TNF category safely. Each of them have their own risk, but they have been game changers. And for many patients, you'll hear expressions like, "I got my life back," and they're back to work and doing the activities before they had rheumatoid arthritis. It's been gratifying to witness.
Are there activities that people with RA are advised not to partake in?
Well, I'll answer it this way. I, and most rheumatologists, encourage our patients to exercise. There are certain types. If you have bad hips and bad knees or bad ankles and feet, high impact weight bearing exercises are not going to be well tolerated, but they can get on an exercise bike. They certainly can swim. I'm a big fan. I'm getting patients to go to their local pool and put on a flotation belt around their waist, go to the deep end and raise their arms and feet in the deep end where there's no impact. Walking is, all these things do wonders for the patient in terms of balance, strength. The most common cause of hospitalization in patients over the age of 75 is falls. They do a great job in helping restore strength and balance. And the physical therapists are key to developing an individualized program that will work for them.
Is there any sort of diet or specific foods that you recommend people with RA eat?
I think the most common diet that is recommended by rheumatologists is the Mediterranean diet. High in fruits, vegetables, nuts, fish, lean meats, low in sugar, and processed foods. Highly processed foods are probably pro-inflammatory and not good for you. There have been studies that show less joint symptoms in patients who've been treated with Mediterranean diet.
So today, what are the options for someone who is diagnosed with rheumatoid arthritis?
It's better than it ever has been. Yeah, like I said, up to 90%, if we can get them early and get them on those medications, the biologics, I would say 90% of the patients can expect to get control in their life back so that they can resume work, prevent end-stage damage in joint replacement therapy. Back in 1950, the year I was born, Philip Hench from the Mayo Clinic won a Nobel Prize in medicine because they had discovered cortisone. And they thought they had the cure for rheumatoid arthritis. 6 months later, it became a very ignominious award because the patients who were on chronic steroids were gaining weight, fracturing bones because of osteoporosis. There were all kinds of side effects, including infection. So now we treat steroids sparingly. We may use them early because they're quick to work, but we try to get the patients off them as soon as possible. It took until 1990s before the biologics came about. But we made remarkable progress, and it's no longer something that people should lose sleep about when they have the diagnosis because there's plenty of good treatments available.
Do you ever see children with RA?
Oh, yes. And there's 3 pediatric rheumatologists at Upstate who are quite busy. And yes, juvenile rheumatoid arthritis remains alive and well. We use the same medications primarily to treat them, and they do much better. And they handle the immunosuppressive drugs better than most adults, I should say. But yes, that's a common problem.
Are people who are diagnosed with rheumatoid arthritis, are they followed by rheumatologists, or do you see some people that are treated just with their primary care provider?
If they're on an immunosuppressive drug, typically they're followed by a rheumatologist. In conjunction with their primary care, we still need the primary care doctor to stay involved. Unfortunately, there's manpower shortage of rheumatologists nationwide, including Syracuse, where there's a backup to get a patient in a timely fashion. But if they're on immunosuppressive medication, because of the complexities involved in proper management, rheumatologists should be involved.
Dr. Riccardi, thank you so much for making time to tell us about rheumatoid arthritis.
My pleasure.
My guest has been Dr. Patrick Riccardi, an assistant professor of medicine at Upstate specializing in rheumatology. The Informed Patient is a podcast covering health, science, and medicine, brought to you by Upstate Medical University in Syracuse, New York, and produced by Jim Howe. Find our archive of previous episodes at upstate.edu/informed. If you enjoyed this episode, please tell a friend to listen too. And you can rate and review the Informed Patient podcast on Spotify, Apple Podcast, YouTube, or wherever you tune in. This is your host, Amber Smith, thanking you for listening.